Welcome, everybody. Good afternoon. My name is Roger Kirby. I'm President-elect of the Royal Society of Medicine, and it's my honour today to preside over this webinar where we're focusing on COVID-19 in the older population. And we've got a stellar cast of experts, including Dr. Jugdeep Dhesi from Guy's and St Thomas's, who's going to focus on inpatient care. We've got Professor Adam Gordon from the University of Nottingham, who is going to talk to us about care homes and the management of elderly patients there. And we have Professor Gill Livingston, Professor of Psychiatry from UCL, with a special interest in dementia. So I think I'll start off with Gill, if I may. Gill, the number of years lost by elderly patients who actually succumb to COVID-19. Could I have your thoughts on that?
Thank you. It's really interesting because I think that there's been some misrepresentation of this, and what we've found, or what other people have found, is that if you think about people aged over 50 who die of COVID, on average, men are losing 14 years of life and women 12. And even if we look at people aged over 80, say on average 11 years. And when we look at the most frail people, they are on average losing 2 years of life. Of course, some will lose more and some will lose less, but this is a real reduction in the length of the lifespan caused by COVID.
Thank you. So then, Jugdeep, the susceptibility of the elderly to COVID-19, we know that comorbidities, including hypertension, diabetes, cardiovascular disease in general, but do we now understand why the elderly, why age is such a risk factor for this disease and the morbidity?
Yeah, so we're lucky to now have emerging data from studies like COPE, which was published yesterday in the Lancet, and other work which has been submitted to other gerontological journals as well, demonstrating that probably kind of older people are susceptible partly because of physiological decline that occurs with normal aging, but also because of that prevalence of multimorbidity, where we know that the average 75-year-old has at least 3 coexisting conditions, which are often things like diabetes, hypertension, and ischemic heart disease, but also because older people are more likely to be frail, and frailty demonstrates a vulnerability to stressors such as viral infections, such as COVID. So it's no surprise really that we're seeing that this condition is particularly affecting older people, such that 70% of people admitted into hospital with COVID have been aged over 65 years, and 50% of people coming into hospital have the underlying syndrome of frailty. So I think there's some explanations there as to why this condition is particularly affecting our older population.
Well, thank you. Adam, then, the frailty score, which has been written up recently, is that, you think, a practical way of clinicians judging the risk of COVID in this population?
I think that there is now reasonable data emerging that frailty does predict adverse outcomes in COVID, as it does in most conditions. The challenge, of course, is if you're not careful and you don't caveat that information appropriately, you can end up excluding whole portions of the population from treatment that they might choose or might benefit from. If you take the care home population as an example, almost all of the care home population, if not all of the care home population, would have a clinical frailty score of 5 or above, which in the NICE guidance was a cutoff for access to intensive care. Now, some colleagues have interpreted that as saying, well, care home residents therefore would benefit in limited ways from access to hospital care, which of course is not the case. There's quite a lot of care you can have before you get to intensive care in hospital. It's not to say that that's not useful in care homes, but it really needs to be a carefully caveated and contextualized discussion if you're going to raise frailty as a basis for making clinical decisions.
Thank you. And the other issue, I think, coming back to Gill again, is the issue of dementia and as a specific risk factor for COVID. How does that work, Gill?
I think the answer is we're not 100% sure how it works, but we know that it works, that the commonest comorbidity and death certificates in the UK from people who died of COVID is dementia, that people with dementia in care homes are more likely to develop COVID and more likely to die from it. And there could be several reasons for this. First of all, most people with dementia are aged over 80. And we know, as Jugdeep said, that old age is in itself, with physiological changes, a risk. Secondly, they're particularly likely to have multimorbidity, and that is a risk. Thirdly, they may have a great deal of difficulty looking after themselves, and certainly people in care homes are there because they can't look after themselves and they can't avoid other people and they can't self-isolate, so maybe more likely to get it. Lastly, it is likely, although we're not sure, that dementia is in itself a risk factor. It is for everything else, that people who have dementia and other illnesses tend to do worse. So it's highly likely that it's true in this case, although we can't be absolutely sure.
Right, and we'll come back to the issue of the longer term issues, and I'll be asking you about whether it's like this COVID is likely to make dementia worse. But we've had quite a few questions coming in. We had actually, I think, 70 before we started even, and please do send more questions in, but I can't promise to be able to pose them all. But a lot of doctors, because this program is for clinicians, by clinicians, a lot of doctors are asking, when they ask to see a patient, this would probably be a general practitioner, although actually I received a call myself from a patient's relative asking, should we call an ambulance? Should we send that patient into hospital? And maybe we should bring Adam in as well on this, because patients in care homes, how do you make that decision as a doctor when you're asked to see a new case with the suspected COVID, whether you should call an ambulance and send them to hospital or not? Any thoughts on that?
So I'll come in. The answer is that as a doctor or as a healthcare professional, is to remember it's not all on you. The ideal way to approach these decisions, which are complicated and complex and can't be fully informed by evidence, because no patient in the cohort studies exactly looks like the complex older person in front of you. You have a whole team of people around you that can help you make that decision, particularly the family, particularly the patient, but also in a care home, the care home staff as well. And I think as a healthcare professional, it's important to move away from sort of cold objective decisions about whether someone is likely to benefit from treatment or not. Those can often be very difficult judgments to make, but instead factor in patient preference, family preference, and an element of individual choice. And I find often when I'm having these conversations, admitting to a degree of uncertainty is very helpful to families and to patients. I'm not sure if going into hospital will be of much benefit to you. I want to know how strongly you feel about hospital being the right place. And if it is possible that you could die from this, would you want for that to be in hospital or in your care home? And actually open up some of the dilemmas and share some of those dilemmas. And I find that's a particularly fruitful way to pick my way through often quite difficult decisions.
And that raises the question then in care homes of whether facilities to give patients oxygen, fluids, and even dexamethasone, do you think that is there or should be there?
Yes, I think that interestingly in the past, care homes in the UK haven't really had access to oxygen or subcutaneous fluids. Access to those things have opened up during the pandemic. Oxygen and subcutaneous fluids, not yet dexamethasone. I'll come back to that in a minute. And I think that sort of dispenses with a false dichotomy. In the past, the patient would have had to have chosen between active treatment in hospital or remaining in their care home for largely palliative treatment. That middle category now is potentially available where they can have active treatment but remain in situ. And I think that's quite an exciting addition to the sort of decision-making toolkit we have when we're working with care home residents. The data for dexamethasone in hospitals is largely for people who are on oxygen or who are are in intensive care. Clearly, some of the people remaining in care homes are the type of people who would be on oxygen if they were in hospital, but they're also a particularly complicated and complex group of patients from a medical perspective, with lots of multimorbidity and lots of polypharmacy. So I think before we start resorting to blanket use of dexamethasone in care homes for people that require oxygen, we really need more trial data focusing specifically on the care home population. And I'm aware of at least one bid which is currently sitting with the NIHR rolling call, which is looking at a specific trial of dexamethasone in care home residents.
Well, as an evidence-based expert, that's the answer I was expecting, Adam. So, Jugdeep, you're in the front line in the accident and emergency department, and you know, patients must be coming in there, and you're having to make decisions there on whether, I guess, they go straight to ITU or whether they go to the wards and so on. Just tell us a little bit about how those decisions are made, and are they based on symptoms? Are they based on measurements?
So a lot of our patients, as I've kind of said already, are older and they're presenting with these syndromes of frailty and multimorbidity. And we know, again, from recent studies that this group of patients often present with atypical presentations, such as delirium, which may be hypoactive or hyperactive delirium, or other constellations of symptoms as well, such as even diarrhea. So not the kinds of things that you'd normally expect to see when someone presents with a viral pneumonia. So I think one of the most important things is to have the right people at the front door so that we can pick up on those atypical presentations as soon as people hit that the A&E department, and make sure that the right healthcare professionals are assessing the patients. We also know with COVID that people can drop their oxygen levels, have low oxygen saturations, but not actually feel breathless and not complain of breathlessness. So you need to have a very structured approach to assessing the patient, assessing those objective scores, and then, as Adam has already mentioned, having discussions with the patient, with their family, with the carers, back with the care home, to identify what other issues may have been that we should take into consideration when planning their treatment. And so making decisions very early about whether patients are going to be managed on our medical wards, where that's actually where we've seen the majority of our patients with COVID, or whether they should be going to critical care facilities, and having, again, very clear discussions with our critical care colleagues about who will benefit from critical care and who may not benefit from it. So all of that happens very rapidly in the A&E setting, but it does require the right team at the right time assessing patients and using objective scores to do that.
There's a question from Catherine Geary saying, is delirium a presenting complaint of COVID? Have you seen that, guys?
Yeah.
Did the Prime Minister have that when he came in?
So I don't think the Prime Minister is probably characteristic of our older, frail, multimorbid population. Right. And as far as I know, he didn't have delirium when he came in. But certainly in the population that we're talking about at the moment, delirium is a very common presenting symptom or sign. And it's often not recognised. So Daniel Davis's group from UCL has shown that about 50% of delirium in the COVID population wasn't recognised at the front door. So yes, it's common, it's under-recognised, but it is a very good marker of, or a predictor of adverse outcome. So it's a really important thing to be picking up early and managing appropriately.
Thank you.
I was just going to add to that, if that's okay.
Sure.
What we've seen from the cross-sectional data in the care home population is that atypical symptoms are the only presentation of COVID in up to about a third of residents. And the most common atypical presentations are anorexia, which is probably a manifestation of delirium, reducing your oral intake, and confusion. So actually, delirium might be the only presenting feature of COVID in the care home population, and not the sort of typical things like breathlessness, coughing, and loss of taste and smell.
Right. Well, we had a lot of questions in, Adam and Jugdeep, as well as Gill, about this decision to move, I think it was 30,000 patients from hospitals to care homes to make space for the sort of anticipated wave of patients coming in at the beginning of the epidemic. And of course, there's been a lot of media coverage of that. But what are your thoughts on that? Was that a really massive mistake?
I think it's easiest to answer that in the context of what we know now. We know that up to a third of care home residents may be asymptomatic. So relying on symptoms to decide who to swab is no good. Early in the pandemic, care home residents couldn't get swabbed. And even when we started swabbing mid-April, only the first 5 residents would get swabbed. So we were missing heaps of COVID in the care home sector. So there's a twofold risk in returning people to care homes from hospital. One is that they could take COVID from hospital to the care homes. The second is that they could be introducing people from hospital unwittingly into a COVID-rich environment. So it's very clear that early in the pandemic, in fact, as far as early June, we were flying half-blind with regard to the care home sector, and that was no way to manage a highly vulnerable population. Another issue worth pointing out is that a lot of assumptions were made about the ability of the care home sector to be able to accommodate people in a cohorted way. And the national guidance said to cohort people who might have suspected COVID without suggesting how to do that. And as Gill's highlighted, if someone has dementia or delirium and wants to walk, there's very little you can do in a care home setting to stop that from happening. And even now, some 3.5, 4 months into the pandemic, there is no specific guidance on how to allow people to wander safely through your care home from government. Care homes have had to rely upon guidance from third sector organisations in order to work out how to manage these sorts of residents. So there are lots of ways in which the infection control in care homes was suboptimal in the pandemic, and I think really we could have done a lot better.
Mm-hmm.
And I think the other thing, probably, Roger, to add to that is that I think what this really showed us was the disconnect between our healthcare systems and then the social care systems, and the disconnect between hospitals and care homes. And it really has highlighted the fact that we need to integrate these services much more, so that we're having the same approach to medical management of patients across the sector between community and secondary care, and ensuring that that communication is much more open, and the appropriate healthcare policies are in place across the different sectors.
Yeah, that makes sense. So Adam, is it actually possible to isolate a patient in a care home effectively? And then a subsidiary question to that for Gill is, if you can isolate them, there's a question coming in actually about loneliness at home, as well as loneliness and isolation in a care home. What longer term impact is that likely to have? I think the word deconditioning is sometimes used in this context. So Adam first.
So I'll take the first part of that. Is it possible to isolate someone safely in a care home? Well, it's clear that different UK administrations disagree on this. In Scotland, someone has to have a negative COVID swab or to have been isolated for 14 days until they go into a care home. In England, the guidance is still that people can be isolated for 14 days in a care home and then enter the care home population. So our different administrations, despite having different similar care home sectors, have made very different decisions about what is possible and what is safe. I think the care home staff are getting much more expert in terms of isolating people as this goes on, and relying upon infection control and cohorting advice from third sector organisations. It's now clear that we don't have to confine people to their rooms if the design of the care home building is such that areas can be partitioned off or separated off. So you can have red areas where people can move more freely and walk about more freely, rather than being confined to their rooms. It's also the case, I think, that the PPE supply to care homes has improved dramatically over the course of the pandemic, so we can now be confident that care home staff have the right equipment to be able to isolate people. That certainly wasn't the case earlier in the pandemic. But there remains a concern that even where care home staff do have the right PPE, that they have to spend an awful lot of time during the day in very close proximity to people that may be COVID positive. Up to 2/3 of care home residents have some form of incontinence. And if you have fecal incontinence and you're required to be cleaned, that will take a member of the care home staff somewhere in the region of half an hour in very close proximity to you. So there are a lot of caveats and concerns about whether people can be isolated safely in care homes. And it's very clear that Scotland and England have formed different opinions on this.
Deconditioning, Gill, tell us about that.
Well, apart from deconditioning, I wanted to say that it felt like that the advice, first of all, from government was from people who had never been into a care home. It's difficult to get into a care home. You're required to have a lot of care needs. And that means that anybody in a care home has need for basic help, and somebody has to get close to them. So it felt like they'd never been there, and that you need to have clinicians as part of the people who give advice. So if people are in a care home and are confined to a room, then clearly if they are mobile, they're going to begin to lose some of their mobility, and it's unlikely they'll get all of that back. And that's a real concern. There'd also be, if they have dementia, they'll be lonely anyway, but if they have dementia, they probably won't understand what's going on. So they'll be distressed and lonely. The cognition will temporarily, at least, probably get worse. We have been asked as in our clinical work about giving people antipsychotics to try and prevent them from moving around, and antipsychotics are really quite dangerous, very dangerous to people with dementia, and it's clearly not ethical, although people are just doing their best. And similarly, giving people benzodiazepines who are likely to have a respiratory problem is totally inadvisable. Going back to what Adam was saying about the third sector, I think got to sort of have a shout out to the Alzheimer's Society and other charities, that they have really tried to give advice about how you can help people have occupations without having to going too far, how you can help people in general, and to manage with people who you cannot completely isolate, and how you can help reassure people with dementia that these strange people whose voices you no longer recognize, who come in all dressed up, are your friends who are helping you again. So I think we have to sort of see how well they've done, and in contrast, perhaps the advice from government has not been quite as helpful.
And there's, Adam, there's one question about vitamin D guidance in care homes, but I guess the larger question for Gill, well, for all three of you really, is the economics of the care home sector in this era where, I mean, the PPE alone must be costing a fortune, plus all the additional care required for these patients, plus the testing. I mean, all of this is being borne by the care home, not by the National Health Service at the moment. I mean, isn't this really a dire problem?
Well, I mean, a significant financial impact was sustained by care homes early in the pandemic when the NHS as a monopoly provider or purchaser bought up pretty much all the PPE in the country. And care homes found that the cost of PPE might be inflated by a factor of up to 100. So items that would usually cost £1 were now costing £100. That was a sort of level of increase in prices. And a lot of care homes did what they could and put their money out for those things. But at the same time, those care homes that have been affected by COVID, often very excellent care homes through no fault of their own, have lost up to 1/3 of their paying clients. Care homes are predominantly private organisations in the UK, private businesses, and to have a massive increase in your expenditure at the same time as you lose a significant chunk of your income really pushes your business model to the breaking point. And I've seen figures that have suggested that most care homes start to run into trouble with financial sustainability when their occupancy rates drop below 70%. There are significant percentages of care homes around the country where their bed occupancy sits between 40 and 50% at the moment. And unless there are consistent and systematic efforts undertaken by government to fish those organisations out, we will see care home organisations go bust before this pandemic is over. And when that happens, the frail, vulnerable residents that live there will be homeless.
It is rather gloomy prospect. We've got questions absolutely flooding in. We've got one from Marlene Deligua, I think it's pronounced. Maybe this is one for Jugdeep. Some families were shocked to find out that their loved one went to hospital and was allocated palliative care rather than active treatment, I guess, ventilation. Why aren't families consulted about these decisions? She wants to know. Any thoughts about that?
So that shouldn't be happening. Of course, patients, their families, their carers should all be involved in decisions that we're making with regards patients' health. I think what is important within that is understanding of realistic choice, which is when we have to assess patients from a medical perspective, look at all of those factors which will affect the likely outcomes, depending on which treatment options may be available. Discussing that realistic choice with the patient if they have capacity to be involved in that decision, and otherwise with their families, carers, or even the care homes that they may have come in from. And then discussing that realistic choice and making decisions about treatment escalation plans, whether patients should be, where they should be managed, what kinds of treatments would be appropriate, and then advanced care planning, which may or may not include decisions not to resuscitate. That should always be done together with families, and that is what we would all aspire to do. I think there have been difficult situations, though, when patients have come into hospital, deteriorated very rapidly, and there hasn't been very much time to be able to consult everybody as widely as we would like to do so. And in those situations, that's been a very difficult thing for clinicians to manage. But of course, on the whole, all discussion should be together as a shared decision-making process.
There have been a couple of examples in the national media where it's been very clear that the discussions around advanced care planning have been done in a very generalised, non-individualised way and have been mishandled. And I think it's important for those of us, even those of us that take a lot of time to do this right, to recognise that that means that families are primed and potentially may be prone to see the negative side of advanced care planning rather than the positive, and we have to be even more careful in our discussions and our approach to discussions than we usually would be. The second point I want to make is that because of the difficulty with getting people in to visit, both in hospitals and in care homes, families don't always have the same kind of visual understanding or up close understanding of how much their mum or dad or uncle or aunt may have deteriorated during their stay in hospital or during their illness in a care home. And it's important not to take for granted that they understand just how bad things have gotten. And I think those things have to be explored very clearly. There have been a couple of times I've had end-of-life discussions where the last time the daughter saw her dad, he was up and walking around. At the time of having the discussion, a month later into a very difficult and protracted hospital stay, he was clearly at death's door. And it was important to understand what her understanding of how he looked was, so that we could have a sensible discussion from a shared position.
Great. I should have said at the beginning that because we've got three great communicators here, we've allocated 3/4 of an hour rather than half an hour, and we've got so many questions coming in. This is a good one, actually, from Lucio Fumi. He wants to know, are advanced decisions taken into account? In cases of dementia, a person might have expressed several years earlier a desire not to be treated. I suppose that's a question for you, Gill. Is it dementia and advanced decisions?
Yes, it is a question for me, and it's in some ways it's quite a simple question, which is if you've made the advanced decisions when you had capacity and you knew what was going to happen, in terms of what the outcomes might be, then it's absolutely taken into account. There is some argument that none of us had a clue what was going to happen with COVID, and that making an advanced decision, you might make an advanced decision not to go to hospital ever unless you're in pain, and that is very reasonable. But when you look at an advanced decision, you've always got to take into account what the person could possibly have known then. And if things have really changed, then things have really changed. But advanced decisions stand. Advanced care plans, where you don't necessarily need to have capacity and your family has made them on your behalf if they have the legal right, continue to stand. And the more people that have them, the better. If you have power of attorney for your relatives, if they don't have capacity, then you can make the decisions depending on what is actually happening at the time. And really, we should all have lasting power of attorney. We should all have people with lasting power of attorney for us, because you never know what's going to happen in the future.
Right. That sounds like good advice. Then there's a question, another ethical question really for all three of you about the DNR decisions. Very difficult in this particular age group. Somebody says, it's observed that many older patients were given DNR recommendations during the pandemic. Do you think there was a bias due to their age? What are your thoughts on DNR?
Well, it depends on what patient population you see. For most of us who are geriatricians, we're seeing people with quite advanced frailty, often with a clinical frailty scale of 5 or above, and often with complex conditions and significant functional dependency. And if you look at the stats for any of those sort of risk factors, it's clear that CPR doesn't result in good outcomes for most of those people, most of those patients. So, if you're being absolutely cold and objective about it, the decisions that are made about not for CPR are entirely reasonable and justified. I think that you run into problems where conversations are inadequately nuanced, professionals don't allow time to have the discussion in a sensible way, and where people try to force discussions. And I commonly have discussions with non-geriatrician colleagues or junior doctors in our acute medical receiving unit about a difficult discussion that they've tried to have about CPR and they couldn't follow through. And my question is always, why did you have to complete the discussion now? Why don't you just introduce the subject now, and if they're not comfortable to take it to the point of conclusion, we can revisit it again later. So I think the decisions are often justified, but it's about allowing people time to come to terms with the discussion that's being had, and being sensitive in how you approach these things.
Well, Tim Beanland is saying, in view of atypical presentations, have the BGS, British Geriatric Society, and I think Jugdeep, you're a vice president of that organisation, very austere position. They've made recommendations to use pulse oximetry in care homes. And has that gained much traction?
Well, that was my recommendation.
Yeah, that's right. Yeah.
Right,
Adam's also a vice president as well, so we've got two of us here.
Surrounded by vice presidents.
That's right.
I don't know what the
tell us about that, Adam.
Well, I mean, the point was that because people are asymptomatic, you can't see it coming unless you're doing observations. Actually, it's been very well received across the care home sector. Early in the pandemic, a lot of care homes just went out and bought pulse oximeters. They're very cheap. As the pandemic's gone on, NHS England has organised for pulse oximetry to be delivered to those care homes that don't yet have pulse oximetry. So I think that has now become quite widespread. The challenge, of course, is if you're doing pulse oximetry, is how you then interpret the results of that, and clearly that involves quite nuanced discussions with healthcare professionals that work with the care homes in the community. And so another initiative that's taken place during the pandemic has been to couple observations to communication tools like SBAR, situation behaviour advice and recommendation, to enable structured conversations with GPs and visiting nurses, so that care home staff can really work out what to do next when they identify a resident who's hypoxic. So I think that's now out there. I think the structured tools to make sense of it are out there. The next phase, and there are pilots already underway, will be electronic resources to allow care homes to share observations with general practitioners real time, and there are already a number of pilots looking at that type of technology around the country.
That sounds pretty sensible. Well, Alice Byram wants to know how telemedicine's impacted on the treatment of older COVID patients. I can imagine a scenario where Babylon, for example, you've got a telemedicine consult, you've got an elderly patient who's worried that they may or may not have COVID, and you're trying to do an interview on your computer. I mean, that is pretty tough, isn't it? Any thoughts about that?
So it is tough, but I think, we are seeing that our older population are increasingly digital literate, and also that their families and carers can support them with using technology to interact with healthcare professionals. So there's been so not so much in terms of directly assessing patients with regards COVID, but what we have seen is the increasing use of technology for virtual consults with older people for a whole range of other conditions as well. And the British Geriatric Society at the moment is producing some work around that, about how to support the use of technology in outpatient assessment with older people, and how to facilitate that, both with doctors, but with other healthcare professionals, our physiotherapists, occupational therapists, nursing and pharmacy colleagues as well. So I think what COVID has shown us is an opportunity to change the way in which we work, even with our frailer, older, vulnerable population who are able to access and utilize new forms of technology.
Great.
Can I come in for a bit about that? Because we've been trying to do memory clinic telemedicine, and a lot of people just don't want to do it. They're not interested, but and they just say we cannot do it. But we are able to do a lot on the phone, and for some people we're able to do it within computers and using platforms, and then only go and see people who we need to, who we can't do it over. So even on the most cognitively vulnerable people, we've been able to move and do a lot of it, but we can't do everything. And I think it has to be clear that we're going to have to see some people forever.
Sure.
I wonder if I can just come in with an adjunct. Another big thing that's got a lot of press during this has been the ability of video conferencing technology, FaceTime, Skype, Teams, to enable care home residents and people who are stuck at home to speak to their families. And I think that for some older people with dementia or with physical disability, that works well. But we need to remember that it's not a universal panacea. And I think of an anecdote I was told last week by a care home manager of a lady with quite advanced dementia who refused to speak to her daughter on FaceTime because every time she did something, the old lady in the corner of the screen copied her, and that made her a bit paranoid, when of course it was just a picture of her. And so there are a portion of people for whom these sorts of telemedicine, teleconferencing, televisiting things work. There are a portion of people for whom face-to-face visiting is the only solution, and I think we need to look at ways to reopen that as safely as possible in long-term care as soon as we can.
The thing that we've found very difficult is that when we are seeing people face to face, wearing masks, wearing visors, people not being able to lip read and be able to see and engage with us, and that face to face contact. Actually, there is something about being able to see somebody on a video screen where you are able to lip read and hear properly, as opposed to being covered up in all of the PPE equipment. So there's all kinds of interesting things that are coming out of this that we hadn't really kind of foreseen, as to the advantages of technology versus the disadvantages specific to this population with sensory impairment and with cognitive impairment as well.
There's a lovely blog on the British Geriatric Society blog website by a German geriatrician called Matthias Schlegel, called Mindful Communication Behind the Mask. And it's got a very nice diagram at the bottom that just gives some useful steps as to how we can remain as human as possible and as approachable as possible and as clear as possible through the mask, and I've signpost colleagues to that blog if they've got the time to read it.
Great. We're nearly running out of time, but I want to ask you all to just a last question, really, because it looks as though a second wave of this pandemic is coming down the line. Who knows? But it probably is. So, what lesson? Of course, there are many, but what a lesson from each of you about what would you do differently the second time round that we didn't do first off? So, do you want to start off, Adam?
Yeah, if I had one wish, I'll focus on the care homes again, it would be regular surveillance swabbing in the care home sector. And I know that there have been some pilot projects in some parts of the UK looking at this, but it's not widespread. And because up to a third of care home residents are asymptomatic, the only way we will see the next wave coming in care homes is if we're doing regular surveillance swabbing. And we quite urgently need some guidance and recommendations and resources from government to support that.
What about you, Gill? What lessons do you think we should have learned as a country to make us?
I think we cannot discharge people from hospital to care homes immediately, that we have to have some interim step down beds outside of care homes. We know that even when they are swabbed, that these swabs are by no means perfect with 70 to 80% sensitivity. So people have to have an interim time before they go to care homes, so that hopefully many of the care homes will remain free of COVID. And if I'm allowed to just slip in a second one, and we don't move staff between care homes so that the staff themselves affect other people when they've unfortunately been infected. That's my wish.
Thank you very much. Well, Brian Fine just commented that in the last half an hour, we haven't talked much about general practitioners, but I mean, you, Gill, gave a shout out for the charities, Age Concern and the Alzheimer's, but definitely GPs have taken a massive brunt of the work on this, especially in their care home. So we should thank them. So let's go to last point, really, Jugdeep. What would you do differently in the situation of a second wave in the hospital sector?
So I think what COVID-19 has really shown has been the fact that our population who need the most health care and social care are frailer, multi-morbid population, and that the whole of our workforce needs to be skilled up to be able to recognise disease within that group. And to know how to manage those patients. So I think we need a rapid rollout of some quick, straightforward education and training packages across the healthcare workforce to be able to upskill everybody in looking after older people. And so that's some of the work that's being done through the BGS at providing some of those training modules across health and social care sectors.
Well, great. Thank you very much. Thank all three of you. All brilliant communicators. I think you've all got a prospect of a job in the media, hopefully. So just to tell everybody and thank all our listeners, thank you for the questions, our participants. Next Tuesday, we've got COVID and cardiovascular disease. Nick Patel will be talking to Richard Schilling and Sam Mahidin about cardiovascular disease. And then very excitingly, our president, beloved president, Simon Wesley, will be interviewing Jeremy Hunt on Wednesday evening and going to hopefully ask him some slightly difficult questions in the 1 hour In Conversation series. So thank you, all three speakers. Thank you again, participants. Thank you, Maddie and Simon, for helping us make this thing happen. And have a great day, everybody. Goodbye.
Thank you.